onset sepsis. I'm Valerie Garrison. I'm the Director of Initiatives and Engagement with the Colorado Perinatal Care Quality Collaborative. So just a couple of items of housekeeping. This call is being recorded, so please stay muted during the presentations. You can use the Q&A button on your options bar to ask questions during the presentations, and we will discuss those questions at the end of the webinar. If for some reason we don't have enough time to get to all of your questions, we will definitely follow up when we send out the recording as well. So our agenda for today is we're going to give you a brief overview of neonatal early onset sepsis in term and late preterm infants. We're going to share a success story from one of our partner hospitals. We're going to orient you to our new web-based toolkit, and then we'll go through some examples to show you how to implement and practice the sepsis risk calculator and examples of how this has been applied at St. Joseph Hospital. So with that, I will introduce Jamie Cabrera, who's the Executive Director of CPCQC.
Thanks, Valerie, and thank you everyone for being here this afternoon. We wanted to just share a little history before we dive into the wonderful content that you'll all be seeing today. In 2015, the CDC and the Vermont Oxford Network launched a collaborative quality improvement platform for antibiotic stewardship in newborns, and that was called Choosing Antibiotics Wisely. And our state, Colorado, formed the Colorado Antibiotic Stewardship Collaborative. And that's a statewide collaborative that included 17 Colorado hospitals participating in the initiative. When the Choosing Antibiotics Wisely initiative ended, many of these CASC hospitals continued their work to reduce unnecessary antibiotic exposure in our hospital newborns through the CASC NEOs initiative. The CASC NEOs Steering Committee developed this toolkit for hospitals that would like to implement their own neonatal early onset sepsis quality improvement initiative. This toolkit is designed to support teams through a self-directed quality improvement project. It includes tools, tips, and valuable lessons shared by our collaborative members. And before we dive in, I want to say a special thank you and introduction to our CASC NEOs Steering Committee, who has dedicated countless hours, and I do mean countless hours, over a number of years to really pull together these amazing resources that we're sharing with you. First, we have Dr. Bobby Chambers-Ha, who's a neonatologist from Banner Health, North Colorado Medical Center. We also have Tracy Heberlin, a neonatal nurse practitioner with Banner Health, North Colorado Medical Center. She's also one of our original members of our collaborative in Colorado. We have Dr. Jeff Homan, a pharmacist with UC Health Poudre Valley, UC Health Greeley, and UC Health Medical Center of the Rockies. We have Dr. Mary Laird, a neonatologist with Children's Hospital Colorado, Colorado Springs, and the UC Health Memorial Hospitalist at Parkview Medical Center. We have Carrie Montgomery, who's an RN, BSN, MSOL, and Director of Women's and Newborn Center at Platte Valley Medical Center. We also have Melda Music, our neonatal nurse practitioner from Children's Hospital Colorado and Platte Valley Medical Center. Our pharmacist, Scott Sviem, with the CASC NEOs, he's representing us as the vice chair, and also with St. Joseph Hospital from SEL Health. We have Dr. Pamela Zacher, neonatologist and CASC NEOs chair as well. So thank you again for your dedication, your passion, and your commitment to this project. And we're so excited to hand this over to dive into the details of the content here.
Hi, I'm going to start us off with an overview of antibiotic stewardship for neonatal early onset sepsis in term and late preterm infants. Next. I'll spend the next few minutes talking about early onset sepsis, antibiotic stewardship in the context of newborns, and I'll go over some recent past guidelines and the most recent guidelines for evaluation and management of babies who may have sepsis, and then I'll do a quick introduction of our toolkit. I wanted to focus, or to really focus on the fact that we are talking about babies 35 weeks and up. There are very significant differences in incidence and risks for preterm babies with early onset sepsis. The broad and much simplified definition of sepsis is organ dysfunction caused by infection. Next slide. But early on, oh, sorry, back up one more. Early onset sepsis specifically is diagnosed in babies who have blood or a cerebrospinal fluid culture obtained within the first 72 hours of life growing a pathogenic bacterial species. EOS is by definition acquired by vertical transmission and not nosocomially or community acquired. And then one more point about that with regard to the clinical diagnosis of sepsis in general, 80 to 100% of babies who have a positive culture will have or go on to have clinical signs of sepsis. Okay. Vertical transmission occurs when vaginal or genital bacteria ascend during labor, or most especially after rupture of membranes, or as the baby passes through the birth canal. A much less common cause of EOS is hematogenous transmission, where bacteria in the maternal bloodstream crosses the placenta. And while this is rare, it's usually quite severe. It's the most common organism that it's associated is with Listeria. Most common organisms that cause EOS are the same ones that we've all been learning for years: Group B strep, E. coli, and other gram-negative organisms, and Listeria. This figure here shows data on term and preterm infants, so this includes preterm infants, from 1990 to 2008. And the blue line represents early onset sepsis. And you can see that there is a precipitous drop in the incidence of early onset Group B strep sepsis that began in the early 1990s. The interventions that were started then and kind of accumulated were nearly universal screening of women in their late pregnancy for Group B strep colonization, and then a more standardized approach to treating with prophylactic intrapartum antibiotics every woman who was colonized, as well as women with evidence of intrauterine infection, also known as corium neonitis. The incidence you see there of 1.7 per thousand live births in the 1990s has decreased to a stable rate of around 0.22 per thousand live births in 2016. Next slide. This graph picks up a few years before the prior one left off and ends in 2014. This data set is also made of preterm and term infants, and we can see that the rate of Group B strep infection remained low after the other chart left off, and that the rate of all causes of early onset sepsis is under around 0.8 per thousand live births. Again, preterm and term infants. And then click again. The CDC estimates that overall in the United States, 0.5 per thousand live births are associated or affected by early onset sepsis. And to put that in perspective, think about how many deliveries you have in your own delivery center, and say that's 2,000, and most of those are term babies, you'd estimate you'd have on average one event of sepsis per year. We don't know exactly what our rate is in our individual hospitals. You have to really have a huge number of patients to figure that out. The rate of sepsis does vary by region, but in general, we look at that 0.5 per thousand live births. And click again. So in general, sepsis in term babies is a very rare event, but we wouldn't even be talking about this if it weren't a serious event for the babies affected. Most babies who have sepsis go to the NICU, and there's about a 2 to 3% rate of mortality for those babies. And one last point for this, while we're talking about, that's okay, while we're talking about this, is that we use a lot of antibiotics trying to head off those adverse outcomes for babies who may develop sepsis. And next slide. Which leads us to talk about antibiotic stewardship. And I'm going to read here, according to the CDC website, antibiotic stewardship is the effort to measure and improve how antibiotics are prescribed by clinicians and used by patients. They go on to describe that, quote, antibiotics have transformed medicine, making once lethal infections readily treatable. And next slide. But they warn us that 30% of antibiotics or more are prescribed inappropriately or unnecessarily, that patients who receive antibiotics are at risk of serious adverse events, with Clostridium difficile being one of several examples, and that those of us who are not receiving antibiotics are nevertheless at risk of complications from antibiotics, for example, and most specifically really antibiotic resistant organisms which develop from related to antibiotic exposure. Next. This graphic by Roche Diagnostics illustrates the prediction that without really significant changes, infections with antibiotic resistant organisms could become the leading cause of death in the next 30 years. Newborns are at risk of the same problems as adults are of antibiotic exposure, but they have some specific risks. For example, preterm babies who receive extended courses of antibiotics after birth are at increased risk of developing necrotizing enterocolitis, which is a severe life-threatening complication for premature babies in the NICU. And children who receive extended or frequent courses of antibiotics in their first year or two are at risk of later development of obesity, wheezing, and allergies. Next slide. This slide just reminds us that antibiotic exposure is one of many that affect the intestinal microbiome and may increase, again, the risk of allergy, autoimmunity, and obesity in childhood. And next. So to summarize, early onset sepsis in term and late preterm infants is rare. Antibiotic overuse and misuse has serious and potentially lifelong consequences. And it's imperative that we improve our ability to identify babies at risk, monitor and screen effectively, and treat with the right antibiotics for the right amount of time, which includes sometimes treating with antibiotics babies that we do not know for sure yet have sepsis. So that leads us to the evidence-based guidelines. For, probably throughout humanity, people have known that certain perinatal factors really increased the risk of sepsis, and they probably didn't call it sepsis, but death for newborn babies. And then with the advent of antibiotics, doctors were able to identify, for example, babies who'd had very prolonged rupture of membranes and treat empirically with antibiotics. Over the last few years, guidelines have attempted to really further characterize the risk that the perinatal events may be associated with sepsis, and it, with all good intentions, have also guided the use of antibiotics for those at highest risk. As it turns out, the most recent past set of guidelines have probably contributed to really a vast overuse of antibiotics, resulting in exposure of many more babies who than just those who turn out to have sepsis. And next. On the left category, on the left column there, you'll see that there is a set of guidelines from 2010 to 2012 that began with the CDC guidance in 2010, with further clarifications and simplifications through the 2012 guidelines. All of these guidelines recommended laboratory evaluation and empiric antibiotics for babies whose mothers had been diagnosed with chorioamnionitis, and CBCs and other labs, including cultures on some of the Group B strep exposed newborns as well. And these recommendations were made with the understanding that, or the belief at that time, that 90% of babies with sepsis had been exposed to chorioamnionitis. As it turns out, with newer data, at least 50% of babies who develop sepsis do not have a mother who was diagnosed with chorioamnionitis. And somewhere around less than 1% of babies whose moms had chorioamnionitis actually develop sepsis. So somewhere between tens and hundreds, and it's likely hundreds with those guidelines of babies are exposed to antibiotics for every truly septic baby. So click again. So rates of sepsis are lower than they were probably even from the database that those guidelines are based on. The diagnosis of chorio can be subjective in a neonatologist's view. Electronic health records have given us access to just massive discrete bits of data that can help us further suss out really risks of infection. And oh, by the way, laboratory evaluation such as CBC has turned out to be remarkably non-specific, and certain lab evaluation is no longer recommended as it used to be. All of this leads to timing for a new way of determining which babies are at risk and what to do with them. You're going to hear a lot about the sepsis risk calculator in the next few talks, so I'll just talk about the last 3 points. The SRC predicts which babies are very unlikely to have sepsis, reduces the use of antibiotics. The recommendations reduce the use of antibiotics and results in fewer lab draws. Okay. In 2018, the AAP and the Committee on Fetus and Newborn came out with their long-awaited guidelines. Next slide. And the most anxiously awaited piece of the guidelines was, what were they going to tell us about how we should risk stratify or determine which kids were at the highest risk? And click again. The recommendation is that birth centers, not individual providers who work in large groups, should look at these three options and develop their own locally tailored guidelines. And they said we could use the old guidelines, we could use the sepsis risk calculator or other tools, or we could just watch babies closely to see who was getting sick. Click again. The sepsis risk calculator is certainly endorsed by a lot of bodies. I'll be talking about these other recommendations from the 2018 guidelines briefly in the next slides. Next. The link to the sepsis risk calculator is at the top of the slide. I just want to emphasize that the calculator was validated as low as 34 weeks gestational age. The AAP is very clear about the dividing line of 35 weeks, because the risks, again, for preterm babies of sepsis are so much different. The link on the bottom of this slide will be on the PDF and goes to how the sepsis risk calculator was developed. Next slide. And you can go to the next one. You'll be seeing that again. The antibiotic usage rate, or how many kids get antibiotics, is much lower when the sepsis risk calculator is used compared to the 2012 guidelines, leading to the very reasonable question of whether or not babies who should have gotten antibiotics and would have been helped by early antibiotics was lower or inappropriate with the sepsis risk calculator. The long story short from these two meta-analyses is that the antibiotic usage rate was lower, and that there were not missed cases of infection with the sepsis risk calculator, or that they were at the same rate as the prior guidelines. Next. The 2018 guidelines also also remind us to always get a blood culture, use a minimum of 1 milliliter of blood, and that intrapartum antibiotics do not invalidate the newborn's blood culture. And this is important, and it's actually different from guidance from a number of years ago. Next. Ampicillin and gentamicin are still our first choices for empiric treatment, and we should be discontinuing antibiotics if our blood cultures are sterile by 48 hours earlier in many circumstances. And it's unusual to have a need to continue antibiotics if the cultures are negative. We very rarely anymore diagnose pneumonia, and we should certainly be documenting a reason for continuing antibiotics longer after 48 hours if our culture is negative. Next. Antibiotic dosing per LexiComp. All of the print and online resources that I've checked recently have updated dosing. Next. You'll be hearing more about AUR, or antibiotic utilization rate, which is a way of normalizing or comparing populations for antibiotic exposure. Next. And this run chart came from the newborn nursery at my hospital, Memorial Hospital, after we introduced the sepsis risk calculator. I want to point out that we also, in my practice, use the sepsis risk calculator in the small NICU at Memorial and our larger neonatal intensive care unit at Children's Hospital in Colorado Springs for appropriate babies. But the takeaways are that our antibiotic utilization rate dropped after we first just started talking about the sepsis risk calculator, and then after we formally implemented it, and that there was a higher rate and a wide range in antibiotic utilization rate prior to the sepsis risk calculator, when we were ostensibly all the pediatricians were using the 2012 guidelines. It turns out that many were not giving antibiotics to all chorioamnionitis exposed babies. That was, in retrospect, probably medically appropriate, but gives the risk managers at the hospital the heebie-jeebies, and is also probably a medical risk when we don't apply a guideline uniformly. Next slide. I'll talk briefly about the relationship of these two entities. Next slide. The purple circle there is CASC, or Colorado Antibiotic Stewardship Collaborative. That's us, people who are talking to you on this webinar and have put together the resources for this toolkit. We worked with Vermont Oxford Network, which is an international quality improvement and benchmarking organization. We worked with them on antibiotic stewardship, and we're tasked with bringing antibiotic stewardship and the sepsis risk calculator back to Colorado. Next. Our work started off as a collaborative. We went to several sites, and there are several hospitals that have implemented the sepsis risk calculator and began doing some data reporting. For obvious and not so obvious reasons, we have turned to this self-paced toolkit, but our goal on the bottom bullet there remains to provide support and structure so every Colorado birthing hospital can implement the recommendations from the 2018 clinical report. And next slide. This is a key driver diagram. It's one of several resources that is on the toolkit. You can personalize this to your local